Hi, good morning. I'm Dr. Alexis Colvin, and I'm the Associate Dean for Alumni Affairs at the Icahn School of Medicine at Mount Sinai. And it's my great pleasure to welcome all of you to the 2023 Alumni Reunion Symposium. Our reunion event is always a momentous occasion and is particularly special this year as it's our first in-person gathering since 2019. So wonderful to see everyone's faces again. This year's event is particularly special for another reason. We are also honoring the first 4 graduating classes from the original Mount Sinai Medical School. The classes of 1970, 71, 72, and 73 are jointly celebrating their 50th anniversaries this week, and this collective milestone is a signifier of the extraordinary trajectory we've taken since the school's founding. When the Mount Sinai Hospital first established a medical school on East 102nd Street in 1968, it was housed in an old bus garage. That modest structure contained all the labs and administrative offices and just one classroom with no windows. Needless to say, those humble beginnings were just that, a beginning. Today, Icahn Mount Sinai is a powerhouse and a worldwide leader in patient care, medical education, and scientific research. We are the nation's largest sponsor of graduate medical education, and we can proudly say we are one of the country's top medical schools. All of us who count ourselves as alums of Icahn Mount Sinai owe a debt of gratitude to those who were there at the start in the early days. I myself came to Mount Sinai through the HUMED program, now known as FlexMed Early Admissions Program. I knew that becoming a clinician and an educator is what I wanted to do. I'm grateful to absorb the lessons and wisdom of our esteemed faculty and to now count myself as one of them. It's an honor to be here before the graduates of the classes of 1970, 71, 72, and 73 at this seminal moment. It's also a thrill to know that the exceptional, rigorous education that I received and that I now strive to impart is a part of a heritage that can trace its origins to what was established by every one of you. So thank you. I'm also proud to say that our Alumni Association has grown right along with the expansion of our medical school. Now more than 26,000 members strong, our Alumni Association includes alums from Mount Sinai, St. Luke's Roosevelt, and the Graduate School of Biomedical Sciences. These leaders and innovators represent a network of distinction and accomplishment that continues to have a profound impact on the world. Lastly, I would like to remind everyone of the final event in our alumni series this week, a special opportunity on Friday to tour the Arthur H. Alphys Jr. MD archives, along with the open house at the newly renovated Alumni Office and Wish Physician Lounge. The archives tour takes place between 10 and 11 a.m., and the Alumni Office and Wish Physician Lounge will be open from 9 a.m. to noon. Again, that's Friday, and this opportunity is available to all the members of the classes of 1970, 71, 72, and 73 and their guests. You're all encouraged to stop by and say goodbye before leaving this year's event. Thank you, and we hope you enjoy today's symposium program. So now I would like to begin the first symposium track, Healthy Aging, Body, Brain, and Heart, and welcome our presenting panelists. I'll give a brief introduction and then ask that each of you share more insight into your work and role at Mount Sinai. So let's start with Dr. Rosanne Leipzig. Dr. Leipzig is an internationally recognized leader in geriatrics and evidence-based medicine. She is the Gerald and May Ellen Ritter Professor and Vice Chair for Education in the Brookdale Department of Geriatrics at Mount Sinai. Welcome, Dr. Leipzig.
Thank you. Would you like me to speak now? Sure.
Yeah.
I've been here 26 years. I came as a fellowship director and quickly became the vice chair for education. And on my watch and with my great faculty, we have developed the #1 geriatrics fellowship program in the country. If you believe U.S. News and World Reports, for the last several years. We also have a palliative medicine fellowship, one of the first in the nation and certainly the biggest. 1 out of every 5 geriatricians or palliative care docs in the country trained at Mount Sinai. I also recently published a book called Honest Aging, which I laughingly say is a brain dump of everything I've learned for patients and families. And if you're at all interested, this is my plug. There are 30% off flyers at the front desk. So that's my story.
Thanks. Second is Dr. Jane Martin. Dr. Martin is an associate professor in the departments of psychiatry and neurology, director of the Neuropsychology Center and the Neuropsychology Division at Mount Sinai, as well as a neuropsychologist at the Mount Sinai's Alzheimer's Disease Research Center. Welcome, Dr. Martin.
Thank you. I do a few things at Sinai, and I am a clinician. I run the neuropsych service. So any patient who complains about their memory to their doc or whomever usually gets referred to my service. So we assess cognitive functioning. I run a training program. It's an APA accredited training program for doctoral students focusing on neuropsychology. And part of me is in the ADRC, where we do clinical trials on Alzheimer's.
Thanks. And then finally is Dr. Lala. Dr. Lala is an associate professor of medicine and cardiology and population health science and policy, as well as the director of heart failure research and the Advanced Heart Failure and Transplant Fellowship. Welcome, Dr. Lala.
Thank you so much. It's such an honor to be here, especially a part of this all-women panel. My work is really in the field of heart failure and transplantation and mechanical circulatory support. So what individuals commonly think of as the end spectrum of heart disease, but I like to kind of turn that concept on its head, and it's really relevant to what we'll be discussing today. And instead of calling it heart failure, I really am petitioning nationally and internationally for it to be changed to heart function, because it's a continuum, no matter where we start. And I believe prevention is as relevant as it is in the beginning of the spectrum as it is in the end of the spectrum. I have the privilege of running our clinical trials program in trials offered to our patients suffering with conditions that fall under the umbrella of heart failure and heart function. And I also oversee the fellowship program, similar to some of my colleagues here, in training cardiologists and the next generation of heart function cardiologists. So it is a real privilege to be here, and I look forward to an animated discussion on aging. And I feel like I should be referred to your institute for bad memory right away.
And I'm Dr. Alexis Colvin. I'm a professor of orthopedic surgery at Mount Sinai. I'm also the chief medical officer for the US Open, and I specialize primarily in knee and shoulder problems. So let's start at the beginning and answer the question, what is normal aging? Dr. Leipzig, would you like to start with that?
Sure. I think, whoops, there we go. I think there are many different definitions of normal aging, okay? The one that I prefer is what happens to most people as they get older. And the thing that I think is most important about that is the recognition, just because it happens to most people doesn't mean that there's nothing you can do about it, that you need to live with it. There's a lot that you can do. So the best example I know, and you will go with this, is that when I was in training, and probably when you were in training, we did not treat systolic hypertension. We were taught that if we treated it, we would cause strokes. And so people would come in with systolics of 180, 190, and you just sit there. Then the SHEP study occurred, and we found out that if you treat these people, you decrease stroke and you decrease heart failure by 30%. That's pretty impressive. And now we treat it. So it's normal, 90% of 90-year-olds have systolic hypertension and need to be treated. And it's the same for many of the things that happen that bother people as they get older.
Dr. Martin, what is normal aging?
I look at normal aging, it's a spectrum. So, everyone gets referred to our center. They're worried, is this normal aging? The changes that they're noticing, is it normal aging? Is it that middle gray zone? Is it dementia? If so, what kind of dementia? So on a continuum, we've got normal aging at one end, dementia, 75% of all dementia is Alzheimer's. On the other end, the middle is what I call the gray zone. It's MCI, mild cognitive impairment. So what does it mean to be, I have to talk about MCI now, so I'm jumping ahead, because nothing is in isolation. It's, that was question like 4. But MCI means that some of your cognitive functioning, and we have ways to test that and measure that, some of that functioning is not quite where it should be for, quote, normal aging for your age. Because we have statistical norms when somebody comes in and does, let's say, a memory test. They're compared not to some 30-year-old, thank goodness, they're compared to people their own age. So we figure that out. So when performance is not quite where it should be for normal aging, but it hasn't declined to the point that we would call it falling in the dementia range, again, which is most commonly Alzheimer's. It's that middle gray zone, MCI. Ron Peterson up at Columbia, has researched this. I think the statistics are about 15% of people, if you're diagnosed with MCI, 15% a year convert. I call it cross the line over into Alzheimer's. So in 3 years, about half of the people convert. So it's certainly MCI is a prodromal stage for Alzheimer's and puts you at risk. So what's normal aging? There are some changes that occur. In our testing, we capture that because the tests are normed by age. So we know if you're 77 years old and you take our battery of tests, we know where you should be falling given what we call, which we help establish, your pre-morbid IQ. Where were you at best in your life? Because we can't compare you. We've got to compare you to where you were. And we have ways to do that as well. Things like word finding difficulty, that tip of the tongue phenomenon, everybody comes in and says that starts at 30 years old. So how do you know if it's more than it should be? If this is just part of, again, healthy aging, normal aging, what's normal? Only by getting an assessment. So there is a range with normal aging. I want to say now though, Alzheimer's and dementia, you're not lay people, it is not part of normal aging. We used to many years ago say senility. We figured if you lived long enough, you got old enough, you'd become senile. And we know it's not the case.
All right, we're definitely coming back to that topic. And Dr. Lala, how would you define normal aging?
Yeah, I mean, I'll take the cardiovascular stance. I think, especially in the field that I'm in, which is heart failure, there are two types of it, where you can see heart failure where it manifests with shortness of breath due to a very stiff heart. And then you can also see heart failure, again, manifesting primarily as shortness of breath due to a dilation, a progressive dilation of the heart. And so those are the two different types of heart failure we talk about: preserved ejection fraction meaning the amount of blood that's leaving the heart with every beat, and then reduced ejection fraction. And both of those can be seen with aging. And I think all of this comes down to some of the changes that we expect with aging in our cardiovascular system. So one, what we notice is that we're not able to do as much as we used to be able to do, right? So in our 20s or 30s, and however, you want to define, younger ages, that we can run up the stairs without getting short of breath. And then as we age, that becomes increasingly difficult. Again, normalize to your activity level how much that you do to prevent that normal aging process. And why does that happen? So Dr. Leipzig already said that we expect systolic blood pressures being elevated as we age. Why does that happen? Because naturally, as we age, everything becomes stiffer. And I think, Dr. Colvin, you'll agree with that, right? So that's our joints, but it's also our vessels. It's also our heart muscle. So the stiffening is kind of a ubiquitous systemic process. And that stiffening is what is responsible for high blood pressure. It's responsible for shortness of breath that can happen as a natural part of aging, with the heart muscle becoming stiffer and being less compliant and elastic to receive more blood and then push more blood out. Another thing that we see is a natural reduction in the heart rate when we exercise. And I think that's such a fascinating concept, because to me, what aging really represents is a diminished reserve, so that at rest, we are all very similar. We're not short of breath, hopefully, at rest. We're able to carry out things at rest in the same fashion, whether we are quote unquote young or whether we are quote unquote older. But with increasing exertion, however we want to define that, what aging shows us is a diminished cardiac and diminished overall reserve. So what's in store for our energy banks is reduced. And I think from a cardiovascular standpoint, that becomes very noticeable in terms of what we're able to do with ease and what we're not able to do with ease. And then going back to Dr. Martin's point, that's not to say that we can't make those processes better and that we can't slow those processes down. And so prevention is relevant whether you're 20 years old or whether you're 80 years old, to slow down those processes and to keep them under control.
Yeah, I think that the prevention is a great point. So, and obviously as an orthopedist, I definitely see a fair amount of arthritis and tendinopathies. And a lot of the changes, like Dr. Martin was saying, actually happen in your 30s in terms of decrease in bone mass and your ability to build skeletal muscle. So Dr. Leipzig, let's come back to you. So what are some preventative strategies that you recommend to your patients?
So there are a few there are a few things that I recommend. The first, everybody at this table is going to agree, is exercise. If there is an anti-aging, magic bullet, it's exercise. And what I say to my patient, and it's all sorts of exercise. It's aerobic, but it's also strengthening, and it's balance, which is incredibly important, and flexibility. But the one thing that I always tell my patients is you've got to right size your expectations. And that has to do with what you were saying, Anu, that, that if you look at the Boston Marathon, there are people who are in their 20s who win their class. There are people in their 80s who win their class. But the amount of time it takes is extremely different if you're 80 or if you're 20. The 80-year-olds are in the best shape somebody like that can be, all right? So there's a limitation, but there's always a way that you can get better by doing this. Exercise helps mood, exercise helps balance, decreases falls, exercise helps sleep. I mean, it goes on and on and on. So that's the first thing, okay? And if you're not a gym rat, start walking, okay? Just walking is helpful. Move it to brisk walking if you're able to do it. Increase your duration. Okay, it's gorgeous out right now. Okay, Central Park is across the street from here. If you have a chance, take a walk. So that's the first thing. The second thing that I talk to older people about is the importance of fluids, of drinking fluids. Because as you get older, you decrease your ability to feel thirst. And so you can be dehydrated and you don't even know it. And this was actually shown in studies at the Boise VA in the 70s, where they took old people and young people, they dried them out, and they waited to see when they would ask for fluids. And the young people right away did, and the older people didn't. So it has to be a conscious decision to drink, even if you don't think that you're dry, okay? What else? Use it or lose it. Your brain, body, whatever, okay? You need to keep using something. And even with the things that Jane was talking about, when you talk about tip of the tongue phenomenon or anything like that, do your crossword puzzles. Those words will come back easier to you if you've recently used them. So it's really important to do those sorts of things. And diet. So, everybody's concerned about supplements and this and that. Decrease the red meat, increase the fruits and vegetables. It really does seem to make a difference in decreasing frailty in older people. And that's really what we're worried about. It's that loss of reserve that when you're in a stressful situation, you cannot get back. Okay. So those would be my 4 top ones. Oh, and hang out with other people. And make it multi-generational if it's at all possible, okay? Because we're really starting to find through the pandemic that this loss of connection that we've had is as strong a bad risk factor as smoking and obesity, okay? So I'll stop there.
So Dr. Martin, you mentioned that the only way to tell if you're moving into the dementia or MCI range is with testing, or are there other red flags that would signal that you should get a test?
Yes, we wish everybody had a baseline, and when they came to us at 80 years old, they pulled out their neuropsych test report. I had this done at 50. That would be ideal. We do have ways to figure out, again, where someone was at. We don't have to do a full IQ or assessment, but we put this together with, some of the tests from the basic intellectual IQ test, someone's occupational and educational attainment, and figure out where someone was at. But what are the red flags? But I'm also compelled to come back to some of the things that Dr. Leipzig said. So can I say those things?
Of course.
Okay, good. So I want to expand in my realm on all of the things that Rosanne said. So first of all, exercise. In my business of dementia, we do not have a magic pill. There are a few drugs on the market. You all know them, Aricept, which is donepezil. We like galantamine here at Sinai. These are cholinesterase inhibitors. They're not magic pills. Dr. Leipzig knows, they can slow down some memory decline. I think the research shows it's about 18 months to 2 years, and then you progress at the rate you would have anyway. They're pretty benign, why not take them? But we don't have magic pills. So the one area that we have that actually research has shown to affect the brain in terms of cognition is exercise. So that was her first point. For us, it's got to be aerobic, 20 to 30 minutes, 2 to 3 times a week. What does it do? Our brain shrinks normally as we age. It slows down the shrinkage. The hippocampus, which is called the seat of memory, sort of the area in the brain, it increases the volume. So aerobic exercise. Again, in my area, we say treat the treatables. We don't have a pill to fix Alzheimer's. So treat what you can. So again, the cardiovascular risk factors, keep them down so you don't have a vascular dementia. Treat the hypertension, treat the high cholesterol. Social isolation. Even before COVID, it's a risk factor for dementia. And of course, as people age, they lose their partners, they become more isolated, all their friends die or move to Florida, and they're alone. It's one way to keep active, to keep stimulated. There are no magic games that will fix, memory decline, but these things can slow things down and lower your risk for developing. So what are red flags? You want that? What are red flags? Even when someone is declining, we have to figure it out. That's where the detective work begins. It's neuroimaging provides a piece, but it's also that clinical piece, doing a really good interview about someone. And then, of course, we have cognitive tests that we administer, a full battery of tests that cover different brain functioning, literally. So tests of memory, tests of attention, visual spatial ability, attention and concentration, and front of our brain, which of course is what we all call executive functioning. And we can see where is there a decline more than it should be. What I find early red flags, somebody, and all of you have, by the way, what we call cognitive reserve. So people with cognitive reserve, which that's a very interesting area of research, people with just call it luck, whatever, higher IQ just from genetics, and higher levels of education and occupational attainment have kind of this buffer to protect you. You all have it, we have it. You'd rather have it than not. And what that does, it is allows you to compensate when there is cognitive decline or there is a neurodegenerative disorder starting and happening, which is a very slow process. So this cognitive reserve can help you compensate, cover up. We often see those patients, I'm sure Rosanne would say the same thing. Sometimes we see them later. The family brings them in and in our head, we're saying, oh God, why didn't they bring them in sooner? But with such good, strong verbal analytic skills, like all of you, it gets missed often. So what are the red flags coming back? Things like paying, these are basic things, but these are things like paying your bills and managing your finances. I always want to know, are you still paying them? Maybe you're in the marriage that wasn't, with division of labor, you never did it. But are you making mistakes? Are you paying late? Are you somebody who was an accountant and now balancing your checkbook, although no one does that anymore? But, it's become difficult. You're making errors. Managing your medications. Things that, particularly executive functioning tests that are just complex, that involve memory and executive functioning. So those are the things that are red flags. Dad is fine, but the bills are all screwed up. As a perfect example, getting lost, some normal benign forgetfulness is okay. Yeah, when are we having dinner with, the Smiths? Okay, write it down, but.
Jane, I wanted to ask, could you talk about what are the normal, quote unquote, changes in cognition that occur as you get older?
Word finding difficulty, again, that tip of the tongue. It does start at 30. I years ago did a chapter on normal aging. And I found out, oh my God, it does start at 30. But word finding, it usually comes back to you, and a little forgetting or not being able to retrieve the name of that actor or the word you want to use. It's a tough one to figure out, when is it more than it should be? Because some of it is normal, and it is normal to have some forgetting. The difference is this. Function. So we look at, cognitive changes, but we also look at functional decline, just like we really can't give a diagnosis of Alzheimer's. without also functional decline. You can have lower scores on all of our cognitive tests than you should, but you have no functional decline. So then you stay MCI, really. That really is that definition of the line between moving into dementia, Alzheimer's, and staying MCI. So it's about the functioning. When do the things like forgetting, memory, word finding, being able to carry out complex tasks, when does it get in the way with your functioning? That's really the change.
I think that's great. It's great to know that. There are some other things you might be noticing and wondering about, okay? It's going to take you more work to learn new things. It's not as easy as it was. The osmosis doesn't happen that you may have had and been lucky enough to have when you were younger. Trying to do things in your head, without writing them down becomes more difficult. Calculating the tip, figuring out what the trip is, the road. I mean, thank God for GPS and for these little things they're now putting on our bills at the restaurants that tells you how much of a tip that you should be putting in. But there are changes like that, remembering lists of words. I tell the medical students this, it's a good thing that they're doing this in their 20s, because when they get to their 30s, they're going to start having more and more trouble learning lists without having some cues to help them figure out what they were supposed to remember. So there are things that happen as you get older that are just normal. They don't mean you're going to have dementia in your future. Multitasking
Is for the
Nobody
young,
can do it.
not the young at heart. Yeah, multitasking. And people really have to
Concentrate.
our world, and particularly in New York, is about multitasking. However, you really don't have the ability to multitask as you get older the way you do when you're younger. So I tell people, focus on one task at a time, write things down. You can't have the TV on. You're looking at the front page of the New York Times and your wife is talking to you. And then you wonder why you can't remember that article. You really have to be very selective about what you're doing.
So Dr. Martin, do you also agree with doing, we can exercise and build our cardiovascular reserve and that sort of thing, but how do you exercise your brain?
That's very controversial, actually. Yes. I mean, there are all these things that people buy in computer, Lumosity and Posit and tons of, and people will always ask us, should I do crossword puzzles? Should I get this computer game? The research has shown that these, cognitive, computer things, et cetera, it's the issue of transferability. So getting good at that task in Lumosity, et cetera, you can get better at that task, but it doesn't mean it will translate into your life and you'll be able to organize paying your bills better. That's really the issue. You can sharpen your attention. And also, if you have more significant cognitive deficits, doing these games, et cetera, are really too frustrating. So there's a sweet spot, mild cognitive issues, fine. And I say do them. If they're fun and you're not really getting frustrated and upset, do them. But don't expect that this is going to fix something. The one thing that you can do, and the games can help with, is attention. The sharper your attention is, the better your memory is. Because even with a kid who's in their, teens who has ADHD, if your attention is, and they don't have dementia, if your attention isn't good, your memory isn't good. Why? You've got to focus on the stimuli and the environment and encode it, get it in accurately. So you need your hearing to be good and your vision to be good, right? Rosanne, I'm sure, tells all her patients, get your hearing aids on. We say, do you have hearing aids? Oh, yes. I always remember to say, do you wear them? Oh, no, right. And vision. But so you've really got to focus on the information so that and hear it accurately so that you can encode it. Does it stick? So do you retain it so that later you can retrieve it? So attention is the area that the games can help with.
Dr. Lala?
Yeah, I would just say that what is so increasingly obvious to me is how holistic we have to be about our approach to ourselves. Yes. And in modern day medicine, we're increasingly siloed, right? Dr. Colvin takes care of joints, Dr. Leipzig takes care of elderly patients, Dr. Martin takes care of neuropsychiatric diseases, and I'm a cardiologist, and within cardiology, I only look at heart transplant and heart failure. I mean, and pretty soon we're going to have doctors who are just for the right thumb. It gets to that point where so super specialized that we lose the forest for the trees. And I think what is so common for all of us are the same preventative measures, the same holistic approach, the same understanding of what constitute normal aging, which is a lack of reserve from head to toe. And I think, we sometimes under-recognize the important connection between everything, between our joints, between our neuropsychiatric health, between our cardiovascular health, between it all. It's all connected. And I think, from the cardiocentric point of view, the American Heart Association has outlined the life's essential 8. And they're all common to whatever aspect of health you're addressing, right? And so these 8 things are relevant to us whether we have disease or whether we're trying to prevent disease. Because even when we have disease, we're trying to prevent the disease from getting worse. So prevention is relevant from day 1 till the day we take our last breath. And these essential 8 are eating healthy, so increasing the fruits and vegetables in our diet.
Mediterranean diet.
Mediterranean diet has been shown to be efficacious, but in general, we know, are you having a substantial serving of fruits and vegetables on a daily basis? How often are you having red meat? Reduce that salt intake. So that's number 1. Number 2, and I am very guilty of this week because I'm on the CCU service, is healthy sleep. How many of us actually get healthy sleep, right? 7 to 8 hours at a minimum for our cognition, for our memory, for our bones, for our joints. It's all relevant across the spectrum, right? That number 3 is controlling our blood pressure. So it's all, again, all connected. Sleep controls blood pressure, healthy eating controls blood pressure, but being conscious about our blood pressure because there are genetic factors that may predispose us to high blood pressure, right? High cholesterol, number 4, again, genetic factors, again, sleep, again, diet, again, exercise. Again, all interconnected. Number 5 is that exercise. So how can we be prescriptive about exercise? It's one thing to say exercise. It's another thing to say, well, how do I do that? And I love the fact that you brought up that it's not just cardiovascular exercise, but it is balance. It is flexibility. It is strength training. It is endurance. So all of those things are relevant. And how can we be prescriptive about it? The American Heart Association outlines it for us. 30 minutes, 5 days a week. That is what we need to do, and it will affect and prevent all of the issues that we're discussing. And then if you're not able to do that, I try to do that, then it would be at least 150 minutes of intense cardiovascular exercise in 2 separate sittings per week. So that's the prescriptive aspect of it. That's number 5. Number 6 is controlling our weight, having a healthy weight. Right? And what is that normalized to your age, to your gender? Important for us to keep in mind. Controlling our sugar. Again, all connected to our sleep, our diet, our vascular health, etc. So keeping a healthy sugar. Diabetes is exceedingly more common as we age as well. And then the most important thing that we've already touched upon here is the interplay with our psychological, our mental, emotional, and spiritual health with all of these physical attributes that we've already, or physical targets, I'd say, that we've mentioned. And I think we touched on that with the importance of social connection, with emotional, spiritual health, and how much that feeds into what we do from the physical side. So we all know why exercise, of course, we know is so important for reducing vascular stiffness, for improving cognition, for allowing for a reduction in that brain shrinkage over time. But plain and simple, if you're in a bad mood and you exercise, your body naturally gives you a reward by releasing endorphins. And those endorphins then keep you in a better mood. They make you more likely to eat healthy. They make you more likely to want to connect socially. So it's a continuous feedback loop. And so what I would say is one of the most important messages to come out of today is let's take a step back and look at the forest and think about things holistically, because all of these aspects of our bodies are interconnected, and it's so important for us to approach it from that holistic perspective.
So I'd like to just shift the topic a little bit to something Dr. Leipzig and I were talking about. So supplements, a huge market now. And so I get a lot of questions about glucosamine and that sort of thing for joints. And I'm sure, it's applicable to especially brain function. So I guess maybe Dr. Martin, Dr. Leipzig, what happened to ginkgo? And, can I just take a supplement and then?
That clinical trial at the ADRC failed. So I really want Rosanne to respond to this. But I have to say, a lot of patients come in and they say, what can I buy at the health food store? Ginkgo, it was when we were doing the red wine study. I can get resveratrol. Now there's Premagen, is that it? Or, all of these things. And I always say, save your money. Don't go to the health food store. If you really want to be experimental, get in a clinical trial. Things are monitored. They're safe. You don't know what the heck you're getting at a health food store. But
I personally think that the anti-aging supplements market is out of control. Okay, that's putting it mildly. And the idea that just because something goes down in the body, if you replace it, you will make things better. I think we learned with estrogen.
I was
Okay,
gonna say
it
Yeah.
That's
doesn't
an imperfect
always
example.
work. Okay, and it can backfire without a doubt. And we're learning it with testosterone, and we've learned it with growth hormone over and over again. Aging is really complex. It involves lots of different parts of the body. And even I have patients that come in on 15, 20, 30 supplements. I don't know what half of them are. Okay. Selenium, magnesium, all of this stuff, silica. And I think if you do the things that Anu mentioned, those 8 things, you will cover what you need. To my knowledge, we do not know of any single supplement other than calcium and vitamin D, which you can look at the literature on vitamin D and decide what you think. Okay, it's all over the map, but you do need enough calcium as well, and hopefully in food, because again, there's a cardiac concern if you take it in pills. But with those exceptions, and B12, because as you get older, you do have more trouble getting B12 from food. So if you take it as a pill, you will get it. And those of you who remember the old Schilling's test, essentially that's what we were doing for everybody. Okay. We were saying, if we give it to you as a pill, will you absorb it? And everybody will. It's getting it off the food that's the problem. So we do check to see if people are B12 deficient, because that can cause problems, and give them an oral supplement. We don't bother with the shots anymore. But with those exceptions, I think that it's a real problem that we have this unregulated supplement market, which actually you have no idea what's in the bottles. And you see it over and over again. And there was just a study in the Times last week about CBD, what's in the gummy, okay? And we have no idea what's in the gummy. So that's part 1. Part 2 of what I will say about supplements is, if you decide you're going to take them, you really have to let your doctors know, because we don't know if they're effective, but we do know that they can interfere. Okay, that there are adverse events, and there are drug interactions, there are drug disease interactions. So like I was saying about CBD, I had 2 patients over the past 4 weeks who had adverse effects from CBD. I didn't even know they were taking it. Okay, one was taking it for sleep, and she was complaining about waking up like a zombie. Okay, and the other was falling from her CBD. And once we got rid of it, she was much better. So those are my comments on supplements. I don't feel strongly about it.
Oh, sorry, Dr. Martin.
I'd like to just comment on something that Anu said that was the first to come up, which is the psychiatric piece, mood. Don't underestimate the effects of depression and anxiety on one's cognitive functioning, and also, I'm sure, on
Amen.
everything else. We, often will get patients who have what we'll refer to as a pseudo dementia. And what depression and anxiety do is they really interfere. They slow us down. You can be 20 years old, and if you're depressed, you seem lethargic, slow. You not only motorically are slower, but you also process information slower. So your attention is disrupted. A young person even will say, oh, I can't concentrate on reading a book. So when attention again is disrupted, and it can be from depression or anxiety, then of course memory isn't good. So we will evaluate those patients. We will recommend that mood things are aggressively treated. Both could be with psychiatric medication, therapy, exercise.
Amen.
And then we'll retest them sooner than I would typically do. We usually wait a year annually to see how people's cognition is doing, but we might see them in, 6 months, 8 months when the depression or mood things remit a bit to see if they come back to baseline. I just wanted to add that.
Lala, did you have any comments you want to add?
No, I mean, I think that's super important. And I will say that just from the cardiology perspective, we have now integrated, I think palliative care gets a bad rap, right? Because it's, oh, you're quote unquote, you're old, things aren't looking good, you need palliative care. And so what we've done, and this is happening more and more in the heart failure space, is we call it supportive cardiology. And I think that that is something I'm very passionate about is the words that we use. No one likes to hear you're getting old. No one likes to hear anything is failing. So that's why I don't like the word heart failure. And not to diminish the importance or the severity of the disease processes, but more so to allow for more engagement, and not make you feel like it's the end. And palliation sometimes implies that. It's gotten that stereotype when really palliation is support. It's facilitating a mental, emotional, spiritual well-being. And so I think that approaching things again from this holistic perspective, even the word holistic has gotten a bad rap, right? Because you think I'm going to be selling you Chinese herbs or,
Touchy feely.
I'm holding your hand and that's going to cure your heart disease. No, I mean, there's no magic pill, like you said, but the holistic notion is really approaching things from the physical, emotional, and mental perspective. And we all know, in fact, for the first time, the American Heart Association has a scientific statement called The Importance of the Mind and Body Connection. And it's like, well, thank goodness, it's only 2023, but at least we're there now. And I think the research in this space is increasing. And I, for one, I'm a full proponent of it. And I think the more we interact with each other, the more we interface, the better.
Dr. Leipzig, did you want to?
Yeah, I just wanted to comment on the fact that nobody wants to get old. And it's true. At the same time, you're going to get old. And that's real. And so I think it's really important, as you say, to think about the words, but also to think about the attitudes.
Yeah.
So ageism is rampant in this country, okay? I don't have to tell you, you know it. What's interesting is that those older people who had negative viewpoints on aging don't age as well as
Right.
those that have positive viewpoints on aging. And if you think about it, we are incredibly lucky. All right. There didn't used to be this 20 to 40 year period after your kids are grown, you finished working your first job at least, okay, that you can do whatever it is you want to do to a large degree. And people don't plan for it. I have patients that come in and they've been retired for 6 weeks and they're ready to kill themselves. Okay. I'm like, you didn't know you were going to retire? You could have planned all of these things. They don't plan anything. But I really think it's important, and Jane was talking about how you do on cognitive testing, and some of the work that has been done suggests that if you have a negative image of aging, you will do worse on your cognitive test, Becca Levy's work, than if you have a positive image. And so one of the things that I find is my job with my patients is to get people to recognize how lucky they are, what they could be doing, what they are doing, and the fact that lots of them are amazing role models for younger people, to get younger people to recognize that aging is not so bad. It's not that it's better than the alternative. You can have a really good life during those years. So that's my pitch.
I think it's also about empowering patients.
Yes.
I mean, we often are giving bad news, and in my training program, I talk to our interns and externs and postdocs about how to give bad news. You give bad news. We all give bad
We
news,
all get that.
but it's how to spin things and how to live with something, how to live with the normal changes that occur.
Yeah.
It's important.
It's adapting to your new normal.
Yeah.
Right. And again, it's treating what you can treat. So I also, in the training of future neuropsychologists, talk about, I'll say, you're going to learn a lot about medicine. You're going to learn a lot about, even though you're not MDs or PhDs, you're going to learn a lot about different medications, different illnesses, so that they know. And we talk about patients, about balance. The last thing you want to do is fall. And in our business, you don't want to hit your head. Okay. So, urinary incontinence. Well, do they have UTIs? That changes cognition, mood, balance, heart disease, so that they start to understand. Sleep apnea affects cognition. So we will be the ones saying to these patients, we're not pulmonologists. Where are your CPAP? Oh, you have a CPAP, but you don't wear it. You don't like it. Get a new eval. So to understand that holistic idea that all these things contribute to not only your overall well-being and, not only your cognition for sure, but your overall well-being in how you manage this stage of life.
So I think, do we want to open up to questions? I think we're going to have some microphones to go around. I guess while we're waiting for a question, just to go back to Dr. Martin, what you were saying about attention being an important. So how, in a practical way, would you work on that?
Again, not multitask. That's how you can sharpen your attention, is to be selective, be really picky. Somebody is talking to you, you're trying to listen to whatever, you say, hold on a minute, I'll be right with you. Honestly, you want to read something, don't have music on in the background. High school kids, they can do their homework with the TV on or music on, right? You cannot do that. And to expect that you're going to remember things the way you once did. I want to give one anecdotal thing. We saw a patient in our service not long ago, literally last couple of months. He is an MD, a doctor who does some surgery. He's still working. He's 70, I can't remember, 70. They know who I'm talking about, but whatever, early 70s, or 75. And he said, I can't do things the way I used to, and I can't remember this, and I forget the names of certain instruments, and he's going on and on as part of the interview. And I feel I should be on disability because I can't function in my role as X the way I used to. So I said to him, I'm a very practical person. I said to him, well, that's, it's time for retirement. That's why judges have to get off the bench at 70. There is a time. I said, it's not, this is, to think that you're going to perform as an MD at 74 years old, the way you did at 44 years old. Agree, everyone? It's kind of crazy. I mean, none of us do anything the same, right, Rosanne, as we did at 40, at, 70. So well, also, there's a little risk involved there. He's not like a lecturer or English lit professor, he's, yeah, right. So, I said, that's when it's time, it's called retirement. It's not about disability. This isn't a disability, it's aging.
So that's a very important point. I just came back from the American Geriatric Society meetings where we had a debate on whether physicians should have cognitively tested every 2 years or so after the age of 70. So full disclosure, I'm 72 or almost, and I feel like a child. I'm almost 72. And of course, with Biden running for president, there's a lot of discussion about this. And places like Yale have this in practice now. Okay, every 2 years, they have full neuropsych testing done. The surgeons have been the ones who've gotten out in front, actually. And they have not just neuropsych testing, but they have motor testing as well, which I think it's a really interesting question, because the older you are, the more experience you have,
Right.
the more cognitive reasoning you've
Right.
been through.
Right.
Okay.
Wisdom.
Wisdom. Yeah.
100%.
Yeah. When you see that your surgeon has a tremor, you get nervous. Okay. So we just saw somebody, so it's real. But I think this is a discussion we're going to be having more and more as time goes on. The pilots have to retire at 60, and if they pass their neuropsych, 65.
Yep.
But that's it. So I think it's very important that we have these conversations and think about it. For somebody like Biden, I'm just going to comment, okay, if we don't get around the fact that as you get older, you walk more slowly, your posture's probably going to change, You may fall more often. You're going to get up more often at night, unfortunately. Okay. So your sleep's going to be a little more disturbed. That's normal aging. And we kind of have to put that right out there if we're going to have somebody who's 82 running for president.
That's great.
Yeah, I was wondering if you might comment on a word you just used that I was thinking about before you used it, which was experience. I think one of the things that has always struck me about medicine is that it is really one of the most diverse professions. It's not like saying, you know, every doctor's the same. I mean, surgeons have technical skills and manipulations that they need to do that don't necessarily apply to other situations, so that there are brought to bear experiences that even at the advanced age, I'm going to be 76 next month, I'm still practicing, but not in an area that requires motor skills. So that what is that role? And just as a side comment, I was a house officer here after I finished medical school when Sinai became the first medical school to have a geriatrics department. So there's a long history of that. It was a bit of a fight with the dean at the time. I was president of the governance body, and the dean announced one day that they'd hired the director of geriatrics from the NIH to come and start that first department. And he'd given him 3 weeks of curriculum time. I don't know how much curriculum time is there now, but the argument
3 weeks.
yeah, well, some things are consistent. But the argument certainly was that it was not the dean's prerogative to redo the medical school curriculum, which brought up some issues. But that said, we now have, as we've heard, you know, probably the leading department of geriatrics.
Well, I think I'm an endocrinologist, a really old endocrinologist, older than you, a lot older. But anyway, I've been struck by hyponatremia, probably the most common electrolyte. Hyponatremia being the most common electrolyte abnormality in hospitalized patients. So I was a little taken back. I realize older people don't drink as much, but some people drink too much. Some of them who are on thiazides, and that can affect their function enormously. Another thing is medications. I don't know if doctors spend enough time thinking about the medicines that interfere with cognition. I've seen a brilliant person not being able to remember anything and saying, I have to retire, and they're on oxybutyrin, on anticholinergic, for example. I have other things to talk about, but why don't we start with that?
Well, I'll take the medication question because that happens to be an area that's near and dear to my heart. And actually, in the book I just wrote on every chapter, I talk about the drugs that can cause this symptom, okay, including cognitive impairment. There are changes that occur in how you metabolize and excrete and distribute drugs as you get older. And a lot of people don't take that into account. And geriatricians talk about start low, go slow, but sometimes they don't go high enough to get an effect either. So it's a difficult balance. There are certain medications that should be avoided in older people. And Benadryl, for example, is the classic. You know, I get at least 2 patients a year who are referred to me by their families because families think that they have developed dementia. And I get them off their Benadryl and they're fine. It's great because it's the only dementia I can cure, okay? So it's really important. It's also that the more drugs you take, the more likely you are to have a drug interaction. And the older you are, the more likely you are to be hospitalized from drug interactions. So it's something that everybody who is prescribing for older adults, whether they are cardiologists, orthopedists, needs to be aware of, and needs to be aware of their patient's kidney functions, their weight, all of that to get the right dose and the right medication. So I couldn't agree with you more on that.
I'm interested in your recommendations and thoughts regarding alcohol and marijuana.
So you get a lot more bang for the buck for alcohol when you're older, okay? There's several reasons for that. The brain is much more sensitive to every medication. And if you are developing dementia, even more sensitive to every medication. Your balance is off already. Your volume of distribution changes. So most of us have recognized that we have a little pot belly that didn't used to be there before, and that we've got something in the wind over here because you become more fat and less water, less muscle as you get older. Alcohol dissolves in water. So your blood levels are higher. If you're a woman, unfortunately, we get even more fat. So our levels are even higher than that. So I think you need to really cut down, and the recommendation is no more than 1 drink a day. Okay. Marijuana, we don't know. There's no data out there. You know, I talked about my CBD data, but I think it's an area that as you walk through the streets of New York, you can probably get high just walking and breathing at the same time.
But have you found, because I have found in interviewing our patients, that more patients in my cohort, you know, my above 70, let's say, are using marijuana.
Yes. Well, they used it when they were younger.
Right, exactly. That a history. They've come back to it.
They've
They're
come
using
back.
it for sleep or for pain.
Yep.
And right, we don't know.
We need to find out. It's really, really important.
Yes, I guess this is for Dr. Leipzig and Dr. Martin. What do you think about these new anti-amyloid? Again, about these new anti-amyloid biologics. First of all, do you think they have the effect that's worthwhile? Does it affect the 15% who cross over from MCI to Alzheimer's? Is it worth the money because it's going to bankrupt Medicare if they're approved and everyone gets them?
I can answer some of that, and the rest of it will be Rosanne. But we had the first drug get approved by the FDA very quickly. The people at Sinai, in my area, neurology and psychiatry, and in the ADRC were all the researchers were pretty upset. So that was aducanumab. I think it's Aduhelm is the trade name. So that one was like, oh my God. And Sinai actually came together and talked and decided not to administer that. In terms of the neurology group. So that one had it did clear amyloid in the brain. So it did clear amyloid, but there weren't really cognitive benefits. And the risks were, of course, of brain swelling and brain bleeds. Okay, so come along only a few months later is lecanemab.
Right.
I never pronounce the trade name. I don't know what it is. It's whatever. But lecanemab. And that has come out. That's better. I actually spoke to Dr. Sam Gandy, who's quite known in the area of Alzheimer's. I talked to him yesterday, and it is going to be rolled out and be administered here at Sinai, and Rosanne
As
can add to that.
clinical trial.
I think in July, they can, he was saying they can get it clinically as a, patient. I know Medicare it was in the works to approve it. What they found, and you'll carry on, is that, again, it clears amyloid, better cognitive benefits, lower risk of those bad things to the brain happening.
And only $25,000 a year, as opposed to
left that out.
$52,000 a year. The benefits are extraordinarily small. I'm not sure families would even notice them. Okay, so number one, the concept of amyloid clearance has not yet shown that you have an improvement in cognition. That's number one. That may not be all that you need. Number two, there was a lot of anger as to how the FDA went about doing this because they didn't follow their own rules in terms of having clinical trials that showed endpoints that mattered to patients. They basically had clinical trials that had intermediate outcomes, the clearance of the amyloid. They have been approved by Medicare essentially only if you are part of a clinical trial, so we can see what else happens. So that's on this side. On this side, I don't know for the aducanumab. I do know for the newer drug, about half of the people in those trials were also taking the cholinesterase inhibitor. So the thought was that it was a bump from that, but not sure. And
it's geared for MCI and early AD patients.
early AD. But of
Early.
course, once it's approved, as you know, you can give any drug to anybody.
Right.
And the other piece about this is that if you are ApoE4 homozygous, you're less likely to get benefit and more likely to get bleed. Okay. Personally, I think the money should be spent on providing caregivers, okay? And
And
help for
treadmills.
those people who are living, what was that?
And treadmills.
And treadmills. Okay, treadmills for that and caregivers for the people who actually have
But it points to the
Alzheimer's.
desperation
Yeah.
that people, families want something.
Right.
I just want to say also from the cardiac perspective, amyloid has become the biggest buzzword. If you look at the percentage of people who are affected by aortic stenosis, so calcification of the main valve of the heart, it's about 20% in patients over the age of 65. That's an enormous population who have aortic stenosis, many of whom go on to have transaortic valve replacement, right? So it's changed things. So you're doing percutaneous valve replacements. Among patients referred for TAVR, so that's the abbreviation for it, 15% are found to have occult amyloid in the heart.
Cardiac amyloid.
Cardiac amyloid, so in the heart. And so we have, from that perspective, really come leaps and bounds, but it's a different pathophysiology, and it's really important to differentiate the two because there's been a lot of confusion there. And I just want to say that cardiac amyloid is a different pathophysiology from what we're talking about from the neurocognitive perspective. But we have come leaps and bounds in terms of treating cardiac amyloid. And it's actually been a very, very exciting time in our field because we now have biologics that decrease the deposition of amyloid fibrils in the myocardium and decrease that stiffening that you see as a result of cardiac amyloid and allow for greater quality of life, most importantly, greater functional capacity, again, very importantly, and with that, increased survival.
Question. In terms of long-term usage, is there still a belief that the control of blood pressure should be held down to not be too aggressive about controlling blood pressure as you get older? And the question also is about long-term use of Lipitor, which is a thing that's been, I voluntarily put myself on it because of family history. Many years back, every so often, one wonders.
Yeah, thank you so much. I think two really very relevant questions. So I appreciate the opportunity to try and answer them and interested to hear your thoughts as well.
Absolutely.
One is blood pressure we've gone all over the map with blood pressure, starting with what Dr. Leipzig said is that you don't treat hypertension. Then it was, let's treat it very, very aggressively. Then most recently, there have been updates to the guidelines. So what is the blood pressure target that we're seeking for in an individual patient? In general, now we have stages of hypertension. I think that's important to keep in mind. So we have pre-hypertension and then overt hypertension. Generally speaking, people will say a systolic blood pressure of 140 or higher is overt hypertension. And what we have learned is that it's increasingly important, regardless of your age, to control that blood pressure. It's extremely important in the prevention of stroke and cardiovascular disease, namely heart attacks. The exception to this, what I would consider rule, is for those patients who have had previous strokes or who have significant impairment in blood flow to the brain, meaning cerebrovascular disease. There are certain situations where they may need what we call permissive hypertension, in that you want to allow for a little bit more higher blood pressures to allow for higher blood flow across stenoses in the brain. But those, I would say, are the exception and not the rule. So I would advocate for blood pressure control across the spectrum of age, first of all. And second of all, in response to your question as to the statin question, comes up all the time, and we're more and more aggressive now, and we have new biologics to control cholesterol beyond statins as well. And really what the data has shown us is that across the spectrum, it is advantageous to control your blood pressure, similar to what I was saying with cholesterol, similar to what I was saying with blood pressure. I'd love to know your thoughts there, but
Sure.
I have my parents both on atorvastatin. I like to use generic names as well. And it's widely advocated for.
So as another atorvastatin user, uh, There were a series of studies that came out recently called the SPRINT trials that were specifically done to look at how low should you go in older people. And the bottom line is that if they can tolerate the medications, okay, the closer you can get to a systolic of 120, the longer they're going to live and the less cardiovascular and cardiac and stroke problems they're going to have. They even looked at frailty. So frailty is a whole new concept in geriatrics. You may think you know what frailty looks like, but like the Justice Potter Stewart used to say about obscenity, okay, you know it when you see it, but there's plenty of times that people are frail and you don't see it. And that's happening in this country because of the obesity epidemic. So people who are obese have fat in their muscles that makes them weaker and more frail.
Yeah.
And they have the same bad outcomes as people who are really thin, okay, and underweight. So they looked at frailty in these populations and they found that even for frail people, the lower you could get the blood pressure, the better the outcomes for them. So it totally changed my practice. I didn't believe it. I wasn't going to do it. And then they kept putting out these studies showing, slicing and dicing. And it's like, yeah, the lower you can get it, the better they do. But again, you've got to be able to tolerate the medications.
And statins.
Statins, we still have this back and forth about primary prevention of cardiac disease in people who are older. The studies are being done, right? The results haven't come out yet. They've done a number of observational studies trying to compare where it does look like even if it's primary prevention, you do better.
Yeah.
So in general, we keep people on statins. It is one of the drugs that when we decide to deprescribe, if somebody wants, if they have a limited life expectancy, et cetera, that we take people off of, I have to say.
And I think it's context is everything,
Right.
right? So your genetic family history, the presence of concomitant diabetes, blood pressure. So I love calculating risk scores and contextualizing it to the individual patient, like you said. I think that is incredibly important. And in cardiovascular medicine, we're becoming better and better at involving patients over the age of 70, 75, up to 80 in our clinical trials. And so the more we have that data, the better it is. I mean, that's even relevant to transplantation. The ethics are very, very controversial, as you might imagine. Should someone over the age of 70 get a new heart? Why or why not? And from 2011 to 2021, there have been 1,000 transplants in septuagenarians. Their outcomes are good. These are pre-selected populations. So age is a number. It's the biologic age that we have to take into account.
Well, I wonder if I could ask you, in your list of 8 that we can intervene and improve health, number 5, I think, was diet. And I want to ask you about fasting, intermittent fasting or restricted time fasting. You probably are very interested in SGLT2s. I am too, because I'm an endocrinologist, and unexpected effects on the heart and on heart failure specifically, and the fact that they are ketotic, and which we fasting forces us to go into our fat stores, generate beta hydroxybutyrate. Tell me about your thoughts about fasting.
I love that. I could go on for hours about this. This has been one of the most exciting advances in cardiovascular medicine over the past 2 years, which is, for those of you who don't know or maybe are familiar, SGLT2 inhibitors were originally developed for better control of diabetes. And what they realized is that they were pretty lousy at reducing our blood glucose, but we noticed a profound reduction in cardiovascular mortality. And then we said, well, if it's,
No, they are pretty good.
they're good, but they're not as good as some of the other agents. Maybe you'll agree with that. And then what we realized is that we took a closer look at those clinical trials, and it was really those patients specifically with heart failure, even at risk for heart failure, that derived tremendous benefit from SGLT2 inhibitors. And so now that has become a recommendation that is a class 1 now, moved into a class 1 recommendation for patients with heart failure across the spectrum of ejection fraction, which is it's a monumental advance. in our field. And so much of what you brought up is, you already took the words out of my mouth, which is really converting what we're using in terms of our energy stores. Is it that we use glucose, or is it that we use ketone bodies? And I think what we're seeing is that it allows, I tell my patients this sometimes from a cardiovascular perspective, specifically if you have heart failure is actually accelerated aging, right? What you can see a 50-year-old person with a heart rate of 110 in heart failure, and that's accelerated aging. It's really the heart just going on overdrive at a premature chronologic age. And so what SGLT2 inhibitors allow us to do is be more energy efficient or fuel efficient. I always say it's like using a solar panel instead. And so it's been remarkable to see the systemic effects, both from a diuretic perspective, from a diabetic control perspective, from a metabolic perspective, and then from a cardiovascular health perspective in terms of reducing heart failure hospitalizations, reducing cardiovascular mortality, improving functional capacity.
The SGLT2, because what you're saying about controlled blood sugar has to do with GFR. Not a good GFR on an older person, you're not going to have any kind of blood sugar control with SGLT2. It relies on losing glucose in the urine. I think we always thought was like, my God, the patients with PKA, look how terrible they are. And it's good. But if someone has good renal function, GFR, a really good GFR, really the potency of SGLT2 to approach anything we have, except insulin and maybe glucose.
And just along those lines, speaking holistically about the whole body, SGLT2 inhibitors also improve renal health and renal outcomes profoundly. So it used to be thought, oh my God, you have bad renal function, don't use the SGLT2 inhibitors. And now that's in fact
So
debunked.
intermittent fasting?
All the good things you mentioned about SGLT2s are seen even as the renal function declines.
Correct.
So effects on heart rate. What isn't seen is the blood sugar control. Once it gets below a certain level, you don't get good blood sugar.
And specifically to that question, and I know we have to wrap up soon, is intermittent fasting. The verdict is, from a cardiovascular standpoint specifically, has not been adequately studied. There was actually a study that just came out in the Journal of American Heart Association, and I commented on it for, I think, CBS News or something like that, where they took a large population, a large health system, and they tried to compare those patients who underwent intermittent fasting to those who had a Mediterranean diet. And it wasn't an adequate, it hasn't been studied in a randomized control fashion, so it wasn't comparing two groups that could actually, where you could have any meaningful conclusion. That being said, I think in certain populations it has advantages, specifically from the point of weight loss. And so again, I think of weight loss as a part of these life's essential 8. And that's really the goal that I'm looking for in terms of improving cardiovascular health. But to date, there has not been any direct association with intermittent fasting and improved cardiovascular health without the intermediate of weight loss.
I think we have one final comment, and then the panelists will be around for questions afterwards.
So I just have to comment on weight in older people, okay? And I think it's important to know that number one, BMI does not have the same correlations as you get older. So people who are overweight or a little obese actually do better than people who are normal weight when you get older. And the recommendation often is to only try and lose weight if you're having a physical reason. So if your joints are hurting, okay, your heart, those sorts of things. So that comment, you can never be too rich or too fat or too thin, is probably not true, okay, because a lot of older people are thin. And the BMI part of that may be that as we get older, we shrink. So it's an equation. You decrease the height, you increase the BMI. Okay.
Okay, great.
Just a comment.
Thank you to the panelists for a great discussion. I know they'll be sticking around for a few minutes for other questions. There's lunch right outside the auditorium, and then we'll resume the formal program at 1 p.m. in here with Dean Charney.